This video is on bowel obstruction. There are mechanical or functional causes. Functional can also be called ileus. Common causes of small bowel obstruction include adhesions, hernias, or malignancy. Adhesions would be most likely if there is a history of adjacent surgery, such as appendectomy or ovarian or other gynecological procedures. The common malignancies that cause obstruction are colorectal, as well as ovary, stomach, and even the pancreas. Large bowel obstruction may be similarly caused by malignancies, as well as volvulus of the colon or diverticular strictures. An ileus means there is impaired movement in the bowel, but not due to a mechanical blockage. This may be due to drugs such as opioids, electrolyte imbalances such as hypokalemia and hyponatremia. Postoperative ileus is another important cause. Hirschsprung's is a consideration in the pediatric population. So how would a patient with bowel obstruction present? The cardinal signs are colicky abdominal pain, as well as abdominal distension, vomiting, and of course constipation. A red flag is obstipation, so not passing wind, because it may suggest a volvulus or complete obstruction, and this is a surgical emergency. It is also important to know how to differentiate small and large bowel obstruction using these signs. Firstly, abdominal distension is usually worse in large bowel obstruction because it's further down the pathway and there's more to be backed up and blocked. Vomiting is usually earlier in small bowel obstruction because it's higher up the pathway and closer to the mouth and contains biliary or green contents, whereas large bowel obstruction presents with later vomiting or emesis and is often brown or feculent. On examination, there may be reduced bowel sounds. If there's third spacing or reduced intravascular volume, the patient may have tachycardia, hypotension, and oliguria. Fever is concerning as it may imply strangulation. It is important to consider the complications of bowel obstruction. There may be ischemia and perforation, and let's understand how this occurs. So obstruction leads to proximal dilation due to continued filling with air and GI secretions up to the blockage. The dilation increases pressure by Laplace's law. When intraluminal pressure is greater than the venous pressure, there is reduced venous and lymphatic drainage, leading to edema and hypoxia, and ultimately ischemia. Ischemic area undergoes necrosis and ultimately perforation. In a closed-loop obstruction, for example, if there's a competent ileocecal valve in a large bowel obstruction, there's increased risk of vascular insufficiency and hemodynamic compromise. Investigations will include FBC and UEC looking for evidence of blood loss and AKI. An abdominal X-ray is the key diagnostic tool. In a small bowel obstruction, an erect X-ray will show an air fluid level with a staircasing pattern. A supine scan will show proximal distension and no colonic gas. In comparison, a large bowel obstruction would show an air fluid level but with a picture frame pattern on an erect X-ray. However, if there is a competent ileocecal valve, there will be no small bowel obstruction air fluid level. On supine X-ray, there will be proximal distension and distal decompression. An ileus would show air throughout with features of large and small bowel obstruction. And we have said distension a lot, but for reference, the normal sizes are 3, 6, and 9 for small, large, and large bowel and cecum respectively. Management, as usual, can be split into supportive and definitive. Supportive includes fluids and electrolytes. As they are in pain, give analgesia, but not opioids, because remember, this can cause an ileus. Antiemetics for vomiting. A nasogastric tube may also be given for gastric decompression with aspiration, which would also help with vomiting. Finally, the patient should be kept nearby mouth with or without total parenteral nutrition as nutritional support. Definitive treatment includes surgical bowel resection to remove the blockage and address the underlying cause. Thank you for watching. If you learned something, please tell a friend who may also find it useful.